Morning, everyone. Thank you for attending this session. Let me advance my slide here. So I'd first like to begin with an introduction in Navajo, which is customary in my culture. Yeah, Juliana Reese, Kapahan Nishmas, Senhabisi, Bashishun, Kiaani, Edishachedo, Ashini, Edishanella. My name is Juliana Reese. I'm originally from Fort Defiance, Arizona. Growing up on the Navajo Nation, I witnessed much of the beauty and richness of my culture, but I also experienced a lot of the daily challenges of being Native American in our society currently. I am honored to be able to speak with you today and hope I can give you some information that will help you in your journey to wellness moving forward and give you some understanding about what's been happening in our communities throughout and likely post this pandemic. So this presentation will be focused on treating substance use disorder in Indian country, specifically how historical trauma and social determinants of health contribute to substance use disorder. It's also about the treatment model, about incorporate cultural humility and trauma-informed care. Lastly, the importance of supporting recovery during and following a pandemic. The course will look at some general statistics in relation to the local area. And when I say local area, I'm in Albuquerque, so it's looking at the Southwest Albuquerque, New Mexico region. Find some opportunities for the future. I'd like to thank both Bridget McNulty and Larry Wissow for their work and contributions to this presentation, in addition to the references I provided at the end of the presentation. So to begin, just wanted to go over some health disparities in American Indian and Alaska Native populations that you all are likely well versed in, but just wanted to kind of frame the discussion, starting with some statistics. 26.6% Native Americans and Alaska Natives are living in poverty compared to the U.S. rate of 14.7%. This is the highest poverty rate of any race or ethnic group in America. The life expectancy for Native Americans is 4.4 years less than the national average. So if you look at those numbers, 73.7 versus 78.1, a marked difference between the general population and the Native population. For reported mental illness amongst Native American adults, this has been about 3.1% higher than the general population. And overall, Native Americans have higher rates of substance use disorder than any other ethnic group nationally. We see higher rates of alcohol, marijuana, cocaine, inhalant, and hallucinogenic use disorders compared to any other ethnic group in the nation. With regard to substance use disorder, we're also seeing higher rates compared to any other ethnic group nationally. About 1 in 5 young adult Native Americans ages 18 to 25 have a substance use disorder, including 11% with illicit drugs and 10% with alcohol. This sort of outlines that the substance use disorders that we are seeing are really multifactorial. They're not just focused in one drug in one area. A lot of times there's just tremendous admixture and overlap between different types of drugs in the community. American Indian, Alaska Native youth and adolescents have the highest rates of lifetime major depressive episodes and self-reported depression than any other racial group. So that's pretty astounding, just as an age group in the United States. Suicide is the leading cause of death among ages 10 through 34, and this is statistics from 2014. Suicide is the leading cause of death in females aged 10 through 14. Rates of completed suicides in Native American females ages 15 to 19 are 4 times higher than that of the white population in America. Rates of violent victimization of Native American Alaska Native individuals, you'll see that term man a lot, and Native American Alaska Native individuals is greater than 2 times the national average. So these are some startling statistics, and these were from 2014. So there's likely some changes in these numbers, but unfortunately they're likely they're increasing versus decreasing. I wanted to touch a bit on opioid overdose mortality because we're starting to see more and more of this in the literature and more focus on opioid and prescription medications that are being misused. The CDC data indicates that American Indians and Alaska Natives had the second highest overdose death rates from all opioids in 2017. This is 15.7 deaths per 100 population, and this is among all racial and ethnic groups in the United States. American Indian and Alaska Natives had the highest overdose death rate for prescription opioids. And so we're not just talking about general overdoses, but this is actual death from overdoses. And that rate was 7.2. American Indian Alaska Natives had the second highest overdose death rates from heroin, specifically at 5.2. American Indian Alaska Native populations had the third highest overdose death rates from synthetic opioids. And so when we bring all of these together, we're looking at the overall overdose death rate for American Indians and Alaska Natives, and this has increased by 13% between 2015 and 2017 alone. There's some fairly recent data that's been put out really focusing on Native American use in New Mexico, and this slide really kind of depicts what's happening with the current drug use and statistics. They did some surveys of high school students and asked in the last 30 days what types of drugs have you used, and more than 1 in 10 Native American high school students in New Mexico, which is 11%, used a prescription pain medication or a painkiller without a doctor's order. And of course, that was within the last month. Approximately 2% reported current heroin use. And mind you, this is a survey that high school students took, and likely these rates are much higher than what are reported. This was actual reported use. Sorry, my slide isn't advancing. There we go. So I just wanted to kind of shed some light on heroin use, and really the heroin use that we're starting to see in the community is really a part of a larger substance abuse issue. When you look at this slide, it really kind of brings this home. Nearly all people who have used heroin have also used at least one other drug. Most have used at least 3 other drugs. We all know that heroin is highly addictive, and it's got a very high risk of overdose and death for any of the users. I wanted to just quickly run through some slides here about anatomy and just kind of bringing to the forefront what drugs actually do to the brain, so that people kind of understand why addiction is so difficult and why it really plagues our younger people and can cause long-term issues with addiction moving on. So really, what does our brain do? There are many parts of your brain, and they have specific functions, and each of them work together to essentially keep us alive. Our brain releases natural chemicals in response to things that we experience. And so this is a normal, natural thing that allows our bodies to be able to survive. It is constantly building itself in response to things we do. So if we expose our brain to music or reading or math or exercise, something that requires coordination or thought processing, your brain actually adapts to that and actually learns and gets smarter and changes as you, depending on what experiences you are having. And so this is a really important baseline concept to understand. One of the chemicals that we are focused on with regard to addiction really is dopamine. Dopamine is released in the brain whenever our bodies experience something pleasurable, like eating, exercise, affection, even using your cell phone. Once dopamine is released, it's taken up by parts of your nerve cells called receptors, almost like little catcher's mitts inside your brain that only catch dopamine. Once dopamine is caught, this triggers a good feeling that your body remembers. And now that's important because this is a survival mechanism that your brain and your body have, that we've had since the onset of human beings, and it really allows you to survive. And so it's an important pathway. This pathway that I'm describing is termed often in literature the reward pathway. The interesting thing is that your brain doesn't distinguish the good things from the bad. It only recognizes the good feeling that dopamine creates. The response is called the reward pathway. Dopamine uses this pathway, and again, it's a natural response that humans have developed over thousands of years in order to survive. If I give you a quick example, so say my favorite dessert is chocolate cake. When I eat a piece of chocolate cake, dopamine is released in my brain, triggering a good feeling so my brain remembers it. Dopamine causes me to have motivation and drive to seek that feeling again, so I eat another piece of cake. When I'm hungry, I crave cake because my body remembers that feeling that I had when I ate it. This is essentially the reward pathway kicking in. Now, it doesn't necessarily mean I'm addicted to cake, although this does happen, and this just gives you an idea of how easily one could become addicted to something because our brains are set up already to seek this reward once it's introduced to our system. Our brains learn from this. We actually change in response to these signals, and they become a part of you. So these slides really just kind of show the human brain at different stages of development. You're all around, or if we look at the brain on the left, it's about 5 years of age. As we move through adolescence, the brain starts changing and becoming more sort of permanently wired. It's not really always permanent, but becomes more, it's using the experiences that you've had since age 5 to develop to where it is at age 20. So if you look at the 20-year-old brain, it's still not quite developed. There's still a lot of green and blue parts in that brain. When we look at this slide, it's really focusing on one part of the brain called the prefrontal cortex. It's a very important part of your brain, and I want to mention it because it's highly affected by drugs. The prefrontal cortex is the part of your brain that controls your adult-like or executive functions and decision-making, controls your behavior, knowing right from wrong, and making good decisions. This slide shows that this part of your brain is one of the last parts to develop. And this is considered one of the most important parts of your body to be able to problem solve, control your impulses, and weigh long-term consequences. So when you look at this, we find that even when you're 20 years of age, your prefrontal cortex is not fully developed. And so we're considering folks to be adults at age 18, yet they're not even prepared to have solid functions of this part of their brain by age 20. So one of the coolest things about being young is that you're building your brains every day, and teenagers are often trying to be more independent. They tend to be courageous and a bit impulsive and like to take risks. And this is normal. This is great. This is what makes you fearsome. And so this is, you're really just amazing learning machines. But again, opioids and drugs in general take over this part of your brain and really kind of hijack this decision-making capacity, and your brain can then form based on that experience in causing some addiction in the future. So I'm going to really switch gears and talk a bit about historical trauma, because I want to also help you to understand how the addiction biologically gets set up in your brain, but also how historical trauma, intergenerational trauma, multi-generational trauma, cultural trauma all really impact the why behind substance use disorders. So I know this is a really sensitive topic, and but it does have enormous impact on Native communities. So historical trauma is essentially the cumulative emotional and psychological pain over an individual's lifespan across generations as a result of massive group trauma. And so Maria Braveheart, or Yellow Horse Braveheart, has coined a number of articles and research in this area. And so I've taken a lot from her research here to kind of demonstrate what is how this really affects our communities. Examples of historical trauma are oftentimes talked about in literature, but not always are they focused on Native Americans. So really, you see a lot of it focusing more on like Jewish Holocaust survivors, African American populations with regard to slavery, Japanese survivors in internment camps even, but there's not a lot discussed about Native Americans and colonized indigenous groups. So this slideshow is really a depiction of colonization and white encroachment in the United States over time, I guess multicultural encroachment on the United States and Native populations over time. And I think it really just kind of shows you in a quick snapshot what has happened, and the link between our substance use disorder and historical trauma is pretty evident. There's the colonization, massacres, disease, starvation, forced removal from traditional lands, government-run Indian boarding schools, assimilation tactics, and cultural genocide, all really culminating to undermine the self-reliance of a people. I wanted to talk just a bit about historical trauma in Native Americans in New Mexico, because that's kind of local to where I am. And many have heard of the Trail of Tears and other atrocities that have occurred throughout history. But in just as recent as 1864, the Long Walk of the Navajo happened, where nearly 9,000 men, women, and children were forcibly exiled from their homelands and marched on foot by the U.S. Army from Fort Defiance, my hometown, to Fort Sumner, New Mexico. This is a distance of about 350 to nearly 500 miles, depending on which route was used. Navajos were held at gunpoint and held in concentration camps for years at Bosque Redondo in the Pecos River Valley. The trek was arduous and the captivity harsh, resulting in the death of thousands from starvation, exposure, and disease. Most historical trauma for Native Americans is closely related to external events impacting them over hundreds of years, but more common examples are the Federal Assimilation and Relocation Acts that resulted in separation of children from their parents in the 1800s and 1900s. So this is really recent trauma that people don't realize often. Many older Native Americans grew up in a time when the basic foundation of their social life that bonds Native culture and communities together was completely severed and damaged. This includes language, values, ethics, and belief systems that are severely challenged by Western missionaries, institutions, and educators. Native Americans lost the right to speak their languages, sing their songs, learn from contact with elder knowledge, connect with nature, bond with their community, and pursue traditional means of survival. Art, ceremonial objects, rituals, prayers, and healings were forbidden, condemned, and as a result, many traditional practices were lost as a living part of Native culture forever. The loss of culture and loss of cultural patterns, identities, relationships, and unresolved massive psychological and physical trauma has resulted in many Native Americans experiencing chronic social problems today. And so this is kind of what sets up a number of the issues that we see in our communities now. As recent as 1953, Congress passed a resolution beginning a federal policy of termination through which American Indian tribes would be disbanded and their land sold. A companion policy, the Relocation Act, followed soon thereafter, which moved Indians off reservations into urban areas. These policies, through these policies, the Bureau of Indian Affairs planned to move thousands of American Indian peoples to cities and urban jobs. Unfortunately, this plan really resulted in cultural erosion and disintegration. There was a lot of homelessness and substance use disorder, prostitution, abuse, and the plan didn't quite work out. One positive thing that came about this was a lot of the urban Native Americans kind of came together, and this is what initiated the AIM movement, the American Indian movement in the 1970s. And so looking at cultural erosion and disintegration, I think it's really important to understand that there's many things that contribute to this across Native populations. Racial misidentification, misclassification, and stereotyping. This is one of the most common things that people talk about in the generations we serve currently. A lot of folks will say people don't believe that I'm Native American, or they're always trying to classify me as one tribe or another, or figure out what I'm admixed with, or am I full blood? Am I part? Am I? And so there's this notion that American society has for what they feel and think a Native American is and looks like. And so this is very damaging to communities and to Native populations all throughout the nation, because it really sets up an identity issue from the baseline and really kind of promotes confusion about that. And so in addition to institutionalized and systemic racism that people experience on a daily basis, we also have internalized depression and self-hatred. I mean, the notion of the crabs in the bucket and the super Indian syndrome, which I call it, is really kind of when communities sort of turn on themselves and really start nitpicking one another. You have folks essentially not supporting one another and comparing how Indian one is versus another, as though there's an ideal or a perfect definition of that. And so there's also forced reliance on governmental aid that's happened over generations, decreased economic stability and development in Native populations and Native communities. Confusing generational dysfunction with culture is something we see frequently. People are so desperate to get out of the dysfunction and the negativity that they're experiencing because of all this history, that there's this deliberate rejection of traditional beliefs and lifestyle, which is much more damaging in the long run. So you ultimately end up with this loss of independence and loss of self-reliance and identity, which is quite damaging. So I mentioned briefly 1953 Termination Act and 1956 Relocation Act. This is an actual flyer from one of the communities, and it really just outlines how Natives were being recruited to these urban areas and removed from a very different community to essentially an opposite type of system that they were unfamiliar with. And essentially this ended up in very detrimental effects to most of the folks that were involved. And there were some positive success stories, but there were a number of folks that really experienced true despair and often death. So just quickly touching on the ACE study, the Adverse Childhood Experience, this again kind of, it's a study that was done essentially in a non-Native community initially in 1997 through Kaiser, but it's been applied to Native American communities in many forms since then. And essentially it just looks at the number of adverse childhood experiences and how this influences your health and well-being throughout your life. And the more ACE experiences that kids have, the more likely they experience an early death. And so this is just really evidence-based, startling information that has been used to help screen and understand our communities a little bit better. This is another depiction of ACE, the ACE triangle, and really just kind of pulls together what the ACEs triangle initially represented, but adds a couple more elements of historical trauma and really how this forms the base of the triangle. It's not contributing at a later stage, it's really the base. And so that is significant. This is a slide that I basically like to show. It really kind of depicts multi-generational trauma and how this leads to intergenerational trauma. And I'm not sure a lot of people really understand and get what that means. It really brings into the picture the social determinants of health. If you look at the roots here of this tree, you have poverty, discrimination, a lot of the things we've been kind of talking about, that forms your foundation. And these are community traits, adverse community environments that people are living in. And from those roots, you have this tree that branches out. And it really kind of forms the basis for adverse childhood experiences and how these things continue to happen cyclically. This slide goes a bit further to depict how intergenerational trauma forms the basis for chronic disease disparities among American Indians and Alaska Natives. And a lot of folks they realize how historical trauma can impact addiction and substance use disorder, but not a lot of folks put together the fact that this is the baseline of your chronic disease disparities as well. And if you look closely, it's kind of a busy slide, but they do integrate the historical trauma, the boarding school, the ACE experiences. But this is one of the first slides that I have seen where it really focuses on adult adverse experiences, not just childhood experiences, and really shows how that cycle can continue. And you see a lot of diabetes and high blood pressure and obesity and heart disease. All of these things perpetuate your chronic disease disparities. So again, I mentioned social determinants of health, and just to kind of show you a diagram of that, I've already essentially talked about each of these things, but really these are just common things that people experience in their life that really contribute to their overall health and functional ability. You've heard people say your life expectancy can be basically determined by your zip code and where you grew up. And so that is talking about this. It's the neighborhood that you grew up in, the health and access to healthcare, the quality of healthcare you received, the social community support that you had, your education level, your parents, your grandparents, and then economic stability and how this plays into your overall health. So these things determine your health. I just wanted to briefly throw this slide here because in the Indian Health Service, we're very focused on these factors and making sure that we are providing a type of health care that really meets the needs of the patient. So we're dedicated to patient-centered medical home type of care, which really leads to having the patient in the center of all of this and making sure they have access to all parts of their healthcare, and that we're treating health from a holistic standpoint, not just one thing, not just looking at your blood pressure, not just looking at your depression, not just looking at your sprained ankle, but really being able to pull all that together and treat the whole patient. So the concept of trauma-informed care is very important. This is basically an approach to engaging people with histories of trauma, historical, multi-generational, intergenerational, that takes into account the presence of symptoms and acknowledges the role that trauma has played and can continue to play in their lives. So trauma-informed care is a huge, huge thing right now. There's lots of movements to get staff trained to do this and understand what this means. When you're delivering trauma-informed care, there's really 5 key elements. We're looking at cultural competence, and the newer term here added to it will be cultural humility, and I'll talk about that just briefly in the next slide. But this is essentially the extent to which policies, procedures, and staff treatments are sensitive to the cultures, traditions, and beliefs of the family and youth that are involved in the agency or in the care that you're delivering. You want youth and family collaboration, trauma competence, and this is essentially the same sort of concept as cultural competence, but you want to really acknowledge the trauma and the trauma that's experienced by the survivors and your patients. Physical and emotional safety, you want to make sure that your patients feel this is a non-judgmental environment and that we are here to meet your needs. Trustworthiness, key, of course, in any kind of care facility. People have to trust you, and they have to be able to understand what they can, that they can really divulge difficult things to you in the course of a treatment session. So cultural humility, again, you've heard the term cultural competence, cultural humility. They're essentially a continuation of one. So cultural competence is really the knowledge that you can gain and becoming a little bit more aware of how differences exist with different people. Cultural humility is really a little bit more. It's how you could work. It's really being much more introspective and looking at yourself and understanding how your experiences impact how you deliver care and how you treat your patients, and really kind of coming together and making sure that you're on the same page with all of that. So this is a very brief way to kind of describe what that means, but it's essentially a way to, an awareness of the self is central to the notion of cultural humility. Who a person is informs how they see another person. So making sure that you have self-awareness and reflection in your experience and understanding how that impacts the care that you deliver to other folks. So what does this all look like in practice? I mean, we want to make sure we're doing that patient-centered communication that we talked about. You want to understand the health and effects of trauma. You're collaborating and your understanding of your professional role, that cultural competence, cultural humility, understanding your own history, and then of course screening for these things and making sure you're being deliberate about the care that you're giving. So stress, I wanted to add this in here. Stress is culminated by the pandemic. Really what we're seeing right now is the beginning of a mental health crisis, and it's not only in Indian country, it's across the nation, but as you can probably guess, in Indian country, we're seeing it at a much larger, having a much larger impact. So if we look at stress and how these things affect our health and our mentality, there are lots of aggravating factors that we're seeing because of the pandemic and because of the history and just the environments that we exist in. So number one that we've been seeing with patients is this just overwhelming feeling of grief and loss. A number of folks in Native American communities have experienced multiple losses within their family, and as you know, Native American populations they're very different than kind of the typical nuclear American family, where you have an average of 1.8 kids, and oftentimes, not always, but oftentimes in American society, you see this nuclear family notion, and there's such a disconnection from aunties, uncles, cousins, grandparents, great-grandparents. They know they exist. They may have met them at once. They may see them at Christmas or New Year's or whatever holidays that you may have, but there's really not that ingrained connection that you see in Native communities. We have large extended families, and in Navajo culture, all of my clan relatives are essentially my brothers and sisters, my mom, my dad. That's how I address them in my language, in my culture. And you do form those same significant bonds. So if you were a child who has gone through tremendous grief and loss already with the pandemic, that has culminated. And so by the time kids in Native populations reach adolescence, they've experienced up to a number of adverse experiences that contribute to their stress. And so every community is a little bit different, but there's some commonalities there. So looking at this number two, remote learning, work's been disrupted. All our work routines and the ways that people have figured out how to survive and work and have a family completely changed. There's this notion of loneliness, isolation, and just complete exhaustion by families, and it's showing its impact in mental illness. Financial hardship, this is common across the board with the pandemic. There's just so much uncertainty, there's debt, job loss. This has been noted to be much worse in ethnic minorities and those folks making less than $100,000 a year. So it's targeting the poorer people in our societies, and the ethnic minorities are feeling this on a much larger scale. And then, of course, the racial injustice that we have been witnessing all across the nation for the last several years, even starting before the pandemic. So all of these factors really, really set folks up for a mental crisis. As far as other factors that COVID-19 contributes to with regard to mental symptoms, we're seeing a lot of insomnia, anxiety, inability to concentrate, impaired memory, depressed mood, confusion, emotional lability. People can get very irritable and just be kind of up and down, and these symptoms can linger in folks who've had COVID-19, and they're very real. We're seeing them now and really trying to define this a little bit better in the medical community so that we can have a true diagnosis and start working on ways to address this treatment-wise. But there's also poor coping that's related to these symptoms. People have been isolated and they're overeating. There's a lot more alcohol use, drug use. We're seeing a lot of burnout and exhaustion in families. There's been a huge increase in screen time, partially because people need to stay connected and go to school and go to work through this, but there's also lots of binge watching and just additional screen time that is not contributing to the overall health of folks. And then this all culminates and leads to this hopelessness and helplessness. It's very real. We're seeing this on a tremendous scale right now across the board, and with or without prior symptoms of COVID. But with COVID-19 being at the forefront, we're just seeing this kind of plague our community so much more. So post-COVID-19 concerns, and so just looking at all these things that are happening to our communities, what are we worried about after this pandemic passes, or the later stages of the pandemic? What, as healthcare providers, what are we kind of focusing on, and what are we seeing? So we're definitely seeing an increased prevalence and incidence of mental health disorders, depression, anxiety, psychosis, substance use disorder, and grief. We're seeing an increase in life stressors, like I just mentioned, the financial, employment, education, isolation, weight gain, nutrition. We're seeing increases in suicide, domestic violence, child and elder abuse, and neglect. Recently, we had reports of our ERs being completely saturated with lots of interpersonal violence. So people are getting a bit stir crazy. Some folks are able to get out more than others, and people are often, say you live in a situation that's not the most ideal, and your break from the day is being able to get out and work for those 8 hours of the day. You have a break from kind of the dysfunction that you experience at your home, and when you get back, you're kind of geared up to be able to handle that. With the pandemic, people are isolated to their homes and they don't have a break from that. So we're seeing a lot more domestic violence, child, elder abuse, and neglect. And so this is a very real phenomenon. We're seeing increases in incidence and worsening of chronic diseases. People have been really unable to see their doctors the same way that they were seeing them. And there's been a neglect of chronic diseases like diabetes, hypertension, obesity, cancer, heart disease, liver and kidney disease. There's also the safety and risk in reopening of schools and businesses in communities. People are being as cautious as they can, but there's just this need and this kind of weighing the risk benefit there of reopening your communities, despite having higher incidence of hospitalizations and just knowing that Native American populations experience COVID to a worsening, the severity is higher. So is it appropriate to open your schools and your businesses and your communities to the same degree that other communities are? And that's an economic decision. It's a mental health decision. It's a general health decision. The efficacy of vaccines over time. So we don't really know anything about our vaccines yet. Our longitudinal studies are, of course, can't happen yet. So we don't know the impact of the variants that we're seeing and the breakthrough cases. And we are seeing breakthrough cases in our communities. We've had a number of folks who've been fully vaccinated with both Moderna and Pfizer who've had breakthrough cases of COVID. And some of them have been hospitalized and some of them have been quite severe. And so again, this, in general, folks who are vaccinated who get COVID tend to get it at a lesser degree. But again, comparing patients that we're seeing in our Native communities to breakthrough patients in other communities, it seems again that Native communities are hit just a little bit harder with that, and the severity is to a higher degree. Looking at post-COVID syndrome is something we're really going to have to focus on. How do we treat this? How do we identify it? And making sure that we're helping our communities to the fullest degree. The disproportionate loss of elders and cultural leaders is huge. I mean, there's one tribe in the Plains area where they had only 4 elders that spoke their language, and they lost all 4. And so right now there's just really no one living that was fluent in their language. And so these things are impactful and cause lots of continued issues in the future for the tribe. Reinforcement of trauma and negative cycles. Again, we've gone through pandemics before. We've gone through all of this in the past, and we have survived. But there's also the possibility of this triggering folks and causing more negative cycles and ill coping. I'm trying to zip through these last slides really quick so we can have some time for questions. Addiction is treatable. This is one thing I really want to emphasize, that chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. People with addiction use substances or engage in behaviors that become compulsive and often continue despite harmful consequences. And so there's always this notion that the relapse is part of your disease, and that, you know, there's all this stuff that people are dealing with, but there is hope. It is treatable, and it's something that we can help with. So I just want to make sure that message is relayed. With regard to treatment in Native American populations, there are a number of models that have been used and many successful. So one out of the Cherokee self-reliance model is now termed Native reliance. It's a self-reliance model that's based on 3 factors: being responsible, and what that means is caring for self and others, being disciplined and being able to set goals and pursue those goals, and being confident. Identity is a huge part of this one, and knowing your self-worth and understanding how a lot of folks tend to subconsciously put themselves down and question themselves. And so these are the 3 things that seem to work best with regard to treating substance use disorder. And so this model is being used very actively in Native populations. There are lots of evidence-based substance use treatment modalities for Native Americans. But many very limited have been studied, and so just wanted to say that the trauma-focused cognitive behavioral therapy is one modality that has been culturally adapted, but does not address historical trauma. So some of them meet you part way, and you have to come up with the rest of the notion to help. And so other treatment modalities, not necessarily evidence-based or studied, but still used very commonly, would be seeking safety, prolonged exposure therapy, cognitive processing therapy, EMDR, or the rapid eye movement desensitization and reprocessing, and then child-parent psychotherapy, which tends to go pretty deep into the etiology of issues. For treatment protocol, improvement protocol, I wanted to draw your attention to SAMHSA's fairly recent publication from 2019. Really, it's titled TIP 61, which is the Treatment Improvement Protocol 61, and it focuses on behavioral health services for American Indians and Alaska Natives. Really, it's a long document, but it's the key messages essentially are the importance, acknowledging the importance of historical trauma, acceptance of a holistic view of behavioral health, and not really just looking at individual issues. You really want to kind of bring all factors of wellness into your treatment modality. The role of culture and cultural identity and how important that is. Recognition of sovereignty, significance of community, very different than lots of other communities. So understanding what that community means for that patient. The value of cultural awareness, commitment to culturally responsive services, significance of the environment, and really this kind of brings in cultural humility and the provider's understanding of themselves and their self-awareness with regard to cultural competence. And then of course, just having that respect for many paths and people being at different places along this and very different experiences and meeting the patients where they are. So what can we do? Encouraging adaptability. We want to help patients find meaning and purpose, connection to community. Connection is really important. It's one of the most solid notions with regard to addiction and substance use treatment. making sure that people have some meaningful purpose in their life and connecting them back to their community or whatever community is supportive to them at that time. Continue to reopen services without decreasing our telehealth opportunities. In Indian country, we're really finding that the younger generation is so tech savvy and they actually prefer a lot of the telehealth Zoom type of calls. Even our elder generation who's not so tech savvy but are comfortable using telephones really feel that a telephone visit is something they want to continue. Oftentimes if someone is incredibly depressed or maybe they don't have a ride or they don't have a way to, who's going to take care of the kids when they go to this appointment? There's just so many obstacles that are eliminated with a telephone call. You don't have to necessarily even get out of bed if that's a struggle for you this morning. You don't have to have, you don't have to get dressed and look what you consider to be presentable. I mean, so all of those barriers are eliminated with a telephone call. And so we want to be able to continue those types of things in the future, but also reopen for important in-person visits as well. We want to be able to provide COVID-specific services, whether that's testing, vaccinations, and updated treatments. We want to utilize case managers and the team, your primary care team, to really identify high-risk patients and bring them in and keep in touch with them. We want to promote integrated health models for whole person care. Again, that chronic disease management and behavioral health being addressed together, not separately, where you can eliminate the stigma of behavioral health issues and bring it all into a hypertension visit or a sprained ankle visit. Like it all comes together as part of your patient's care. Providing increased mental health services through multiple means to reduce the mental health issues. So this is going to be one of our focuses moving forward, really pulling in our partners and collaborating and being innovative about how we reach our patients. Expanding substance use services, including medication assistant treatment clinics, increasing education and resource sharing, providing training and support for our staff, cultural humility, cultural competence, historical trauma training, looking for innovative ways to address social and cultural concerns, and really, again, collaborating with our community partners, because we can't do it all, but if we come together, we can always try to cover those obstacles that we see that are preventing our patients from accessing care. So pediatric specific goals, again, we want to reduce the toxic stress caused by adverse childhood experiences, such as emotional and physical neglect, substance use disorder, household dysfunction. We want to reduce the disproportionately high prevalence of overweight, obesity, and type 2 diabetes. And this involves nutrition activities, opportunities for prevention, management, treatment. Would encourage breastfeeding initiation and continuation throughout infancy, introduction of community-specific suicide prevention initiatives, and of course address the post-COVID symptoms that are affecting our youth currently. Other opportunities, really using COVID-related monies to support our tribes through vaccines, testing, post-COVID treatment, broadband expansion, making sure those telehealth opportunities are there for care, educating our patients, kind of covered a number of these things already, but really looking at all those social determinants of health. And if your patient is coming in for one reason or another, whatever the diagnosis may be, you kind of walk yourself through each of those social determinants, that diagram that I showed you. And so how is this depression affecting, what is your transportation situation like, and how is that affecting the depression? And you kind of march through each of those things to make sure you're asking those questions, because if we don't ask it, we won't know. And that was my last slide. I'd like to end with this slide, which I think is really powerful and really just does not even need an explanation. And here are my references. They'll be in the PowerPoint again. Thank you for all those who helped contribute to these to this research, and hopefully this was helpful for you. So I'm okay with answering any questions now.
Great, thank you for that presentation. If you guys have a question, you can just drop it in the chat box or feel free to unmute yourself. We have about 8 or so minutes for Q&A.
Wow, no questions. All right. Any just points of discussion, things people want to bring up, experiences that they've had, anything that's different in your community that you're seeing?
I am calling in from Alaska, and our Alaska Native communities suffered obviously a lot higher, like most Native communities in the country, from the COVID-19 pandemic. And something that isn't talked about a lot that I was curious if you had more information or thoughts on was how climate change impacts Native communities in general. I know it's a huge impact for rural Native communities here. Lack of access to like proper means for sanitation really impacted their ability to cope with COVID, and definitely exacerbated the cases in the rural communities. And I was just wondering if you had any thoughts about how our trauma-informed practice could consider climate change and how that could be incorporated in the idea of cultural humility and just cultural competence with like these unique environmental factors faced by Alaska Native communities, in my experience, but also Native communities in general.
Wow, thank you for that question. That's a really interesting and a powerful point to bring up, because many tribes are experiencing effects of climate change and may or may not even realize it. I mean, in the Southwest here, it may not be as obvious as what you're experiencing there, but it's definitely increasing the stress and the issues in our community with regard to employment. The heat waves coming through, the droughts are largely impacting farming, and even access to lands for hunting. And there's a lot of different, the fishing, the camping that people are trying, the recreation that they're trying to experience. Everything is changing so markedly and really forcing people to do things differently. The heat waves are impacting folks in the workforce. A lot of individuals are now having to change work schedules to work more at night to do construction jobs versus middle of the day because of the heat exhaustion and heat stroke that you're at risk for. And so I think farming and ranching communities and just even personal gardens are really a difficult thing when folks are looking for water and wanting to make sure that they're surviving. So there were lots of media posts on the Navajo Nation about the plumbing and electricity and water issues that were happening. And those are largely increased by climate change, because in the past, people were able to have access to clean water and drinkable water from wells and windmills. And because of a lot of things that have happened over our region, those wells are really not safe or they're dry. And so absolutely, I think there's a huge role for that, and there's a huge place for that kind of information research. I don't personally know anyone who's doing those kinds of studies right now, but I'm sure they're being done. I'm sure they're being looked at. And so if I come across anything, I'll definitely, if you put your email address in the chat, I can get back with you on that. But as of just right this moment, I'm not able to think of anything that I've read recently that focuses on that connection. But those connections are really important to make, because oftentimes that's not, people don't, they hold them so separately and they don't realize how all of it is related. So I appreciate your question.
Yeah, totally. And I appreciate your answer, because it does feel super interconnected, even talking about like lack of access to hunting and farming, and then connecting that to issues of obesity, and like when people are able to do these subsistence practices and get healthy food themselves and have that self-reliance. I just feel like they're all very interconnected. And I'll definitely drop my email in the chat box, and I appreciated your presentation a lot.
Okay, absolutely. Any other comments or questions? Any areas of concern or what? I can't see the chat with my presentation up. I don't know if kind of, can you see if there are questions that were put in the chat?
Yes, someone did say that they really liked your ACEs slides. They were great. Had a few people thank you for the presentation. I did forget to mention in the beginning, the slides will be available along with the recording. We're going to post those on our NIHP website probably in a few days or early next week. So those will be available to those who missed maybe the beginning of the presentation or just want to reference that again. But we do have time for probably about one more question or comment or something that you would like to discuss with Dr. Reese, if anyone wants to chime in.
Oh, we got a shy crowd. All right. Well, thank you all for taking the time to listen. And I am absolutely honored to have been able to do this presentation for you. And if there's anything I can do, I left my contact information. You want any questions answered or just want to connect, let me know. Thank you.
Yeah, thank you so much, Dr. Reese. You had a wonderful presentation. And I will just remind everyone to sign out of this event whenever you're done. I'm going to post it in the chat so you guys can access it quickly. Just in case you guys are wanting the CEUs, you will have to sign out of each presentation today. And then please do fill out that evaluation form. It's going to be really helpful for us moving forward. And you guys have a great day. There's a few more sessions throughout the day, so I hope you guys are able to attend. And thank you so much again, Dr. Reese.
Yes, you're welcome. And you all have a great day.